Interventions with a King. Discussion and commentary based on articles from JACC, Cardiovascular Interventions.
I'm Spencer King. I'm editor of JACC Interventions, and I'm joined today by Dr. Cosimo Godino from San Raffaele Hospital in Milano. Welcome. Glad to have you today. We're very excited about the new process of percutaneous aortic valve, or TAVI, and your institution has published a paper in JACC Intervention that I think is going to be very fascinating, because you've had enormous experience with both valves that are currently being investigated, both the Edwards valve and the CoreValve. Tell us what you have learned about selection of these two devices.
Yes, this is a new experience because there are few places in the world performing TAVI procedures using both valves, and also using the three type of approach available in this moment: the transfemoral approach, the transaxillary approach, and the transapical approach. This possibility gives us the opportunity to select the best valve for the best patient, according to the difficult to find sometimes for some patient a good approach by transfemoral or transapical or transaxillary.
So many of us are involved in one study or the other, so we only have the one valve to work with. But what are some of the advantages and disadvantages of the two that enable you to select and broaden the indication?
In this experience, the advantage to use both valves was related in most cases to the impossibility to use the transfemoral approach, for example, for Edwards, and also the possibility to use the axillary approach for the Edwards valve, and to use the metronical valve is a little bit smaller by transaxillary approach. Otherwise, when the transaxillary approach or transfemoral approach is not possible to use with both, we can use the Edwards valve by transapical. So in our experience, it's very difficult that one patient can receive, if it's high risk for surgical approach, a valve, because using both and the three type of approach now available, we can identify which route is indicated for that patient.
So the valves that we currently have, the big difference until now has been the size, right? One of the differences is the size of the
size of
delivery,
the vessel of the femoral,
which for the CoreValve or the Medtronic valve was much smaller than the Edwards. But now the Edwards is coming with a smaller
yes, the new
system.
Edwards is 18 and 19 French, so are quite similar. So the things are going to change. But we have many patients that have very, very small femoral. So we are going to implant valve also by transaxillary, also with the new Edwards.
Yeah. So we're very excited about those. Are there any things that relate to placement of the valve itself? They are placed a bit differently. You can retrieve the CoreValve, and the other one, the Edwards, has got to be a little more precise. I mean, is there anything about the anatomy of the valve itself that predicts?
The most important difference between the two valves is, of course, that Edwards you have one shot. You have to be very, very, very precise. With the CoreValve, we have the opportunity to change, to modify a little bit the positioning. But we found sometimes more difficult with the CoreValve, and we have some complication, maybe embolization of the valve with the metronical valve, that with the Edwards valve is more difficult. Regarding the anatomy, we prefer to implant the CoreValve when the annulus of the valve is really, really big. We are more sure to obtain a good expansion with the CoreValve compared to the metronic.
These valves, of course, are going to go through many changes in the future, but your experience right now is tremendously valuable. I'm looking forward to this paper in the focused issue of JACC Intervention on TAVI, and which will feature a lot of interesting papers on this subject. We've enjoyed visiting with you today on Inside Interventions. Thank you very much,
Thank you.
Cosimo.
Thank you.